Hi, my name is Erica Gutierrez. I'm a registered dietitian with Weighless RDs, and I'm here to bring you week 2 of our GLP dietitian expert training. And we're going to be talking about optimizing nutrition. So today I went back through all of the research out there on the best weight loss diets. I first tried to find any sort of research on diets with GLPs, and unfortunately, there are none out there yet that are substantial. So I did go back, and I will include a link in the portal here of this research, but it's a grouping of the last 15 years and the best diets related to weight loss. I'm also going to share where we start baseline recommendations for patients on GLPs. Then I'll talk about what people are actually doing. And then we'll talk about those little tweaks, things that people can do a little differently based on what their labs are, any symptoms or conditions that we begin with or encounter during our work with these patients. What to eat, what not to eat is more of a patient resource, and then more additional resources for you. So, what does the research say? This was about diabetes. So that's probably the closest thing, the most common sort of thread with these patients that are on our GLP medications. And what this research looked at was dietary patterns, the Mediterranean diet still being the most well-recognized, most favorable for positive effects for both obesity, diabetes, and many other conditions. Low carbohydrate came up, which makes a lot of sense because it really can help with glycemic regulation and improving insulin resistance. And then we have the high protein diets, the plant-based diets, which they're kind of in conflict with each other, which I'll talk about a little bit more too. But that high protein is really important because it's satiating, but it also preserves muscle mass. And the plant-based diets are very high in fibers. It helps with gut health. They're low in calories. So generally you're eating less calories overall. So another really good way to eat. Timing of meals was another thing that was looked at. So the intermittent fasting regimens really are supportive of insulin resistance and improving metabolic health. So, it's enough for us to decipher and deal with all the conflicting information. Can you imagine what our patients go through? Should I do this diet? Should I do that diet? But it was really cool in this research. What they said in the summary was personalization emerged as a crucial factor during the dietary recommendations. So us as dietitians are the ones that are making the difference for these patients for their success. So, here we start with some discrepancies. We have the Mediterranean diet here and a low carb diet. So you can see it's like almost exact opposite with these carbs. Carbs are at the top at every single meal with the Mediterranean diet, and grains or legumes are at the very least at the top of the pyramid there. So how do we balance this out? And, it goes back to each person is individual. It depends what their patient history is, what their current lifestyle is. There are so many factors, and I think you understand that, but this is where the discrepancy or where it gets difficult, I guess, for patients, and sometimes even for us to decide which one is going to be best for people. So here's the next discrepancy, high protein or plant-based. When you look at high protein, it's so important for that satiation piece and for maintaining muscle mass. It was interesting. I found a study specifically on protein and calcium containing foods. I wonder who is behind some of that research, but that was even showing there's an enhanced effect when there's protein and calcium together with the secretion of GLP-1s. So kind of interesting there. But plant-based, So it's high fiber. It helps with that short chain fatty acid production, which we've talked about previously in other presentations about that the short chain fatty acid butyrate specifically, and how important it is for metabolism and weight management. It's lower in the saturated fats. It's very nutrient dense. There are some compounds that actually, certain plants that mimic the incretin hormones, which is pretty cool. And it's very, plant-based is used widely for weight management, but I think it has a lot to do with the low calorie and plant-based, high density nutrition. So here's where I could talk all day on this topic, but intermittent fasting, I think it gets to the same goal as the GLPs. So if you look at what intermittent fasting does, it helps improve insulin sensitivity. Now, there are some people that I would not recommend intermittent fasting to, someone with high cortisol or poor adrenals. So what we're doing by intermittent fasting, it is some sort of a stress on the body. So someone that is already really high stress, not getting enough sleep, all of that, intermittent fasting is probably not the place to start. But for the people that do benefit from it, you see decreased glucose levels, you see autophagy. So this is where the body has a chance to clean up after itself, and it clears out those insulin receptors. There's hormonal adaptation involved here with leptin. Adiponectin is increased, which is very helpful for preserving lean body mass and not building up too much fat stores. And it switches your body from carb burning to fat burning. So it teaches your body, and it makes your body more easily able to reach those fat stores. And it helps repair important cells. So I'm going to start with understanding what happens when the GLPs aren't working properly. So I think by us actually understanding the mechanism and how it works, that helps us figure out what's the best sort of diet plan and the types of nutrition that we actually need. So for whatever reason, GLP secretion stops working. We've seen that for diabetic patients, for obese patients. And, we think it has a lot to do with gut issues and or poor diet choices. And when these hormones stop getting secreted, that's when the calorie restriction no longer works. Carbohydrates are not metabolized and utilized by cells effectively anymore. This is where we get insulin resistance because we keep pumping out the insulin, yet the receptors are blunted. Nothing's able to actually get into the cell. So what happens is these are the people that are always hungry. Even though they're eating constantly, they don't get that full signal because their cells are still starving, even though there's plenty of food to be found. So I am going to share what we actually do for our meal plans. So we put this into two different phases. Essentially, most people start on phase one. There are very few that potentially start at phase two. These would be people that maybe go on the medication to lose 10, 15 pounds. They're fairly healthy already, but just can't get that last bit of weight off. Most people come in insulin resistant, maybe even high blood sugar, pre-diabetic, potentially diabetic. And we break this down into 3 square meals. There will be some people that choose to extend their fast and only eat 2 meals a day. But typically we recommend they start this way so that they're getting enough nutrition all throughout the day. So breakfast is 3 to 4 ounces of lean protein, and this is uncooked. We do allow some dairy if they can tolerate it well, as long as it's the lower carb option. 1 serving of healthy fat. So we give approximation for calories there. Some people really like a total calorie count. We try to steer a bit away from really just focusing on calories and more about how to balance the meal. Lunch, we have lean protein, 2 servings of healthy fat, a bunch of non-starchy vegetables, and that's where they can have one serving of a whole grain. Some people choose to switch and have their fruit at lunch and the grain at dinner time based on the types of meals they make for their family, and they want to be able to have that carb at nighttime. But we recommend it during the lunchtime in general. And then dinner, you get a little bit more protein. Same thing for fat, same thing for the starchy vegetables. And that's when you have your dessert, which would be a lower glycemic dessert or fruit. So this plan, as you can tell, is low carb. And it's done on purpose. As people start at that lowest medication, we want to be able to jumpstart them. We're having them eat very clean. We're really ramping up their fiber. We're making sure they get protein at every single meal. And so this can be quite a shift for people at times. So it is something we do acknowledge, but people are generally very motivated in the beginning. And if they can follow this plan and start at that lowest dose, it's usually a really good kickstart to get them going. We have a lot of success with MCT oil as well. So this is in most of our plans. MCT is really good at helping with constipation as well. So usually we do about 2 teaspoons a day. People mix it in their coffee or they drizzle it on some of their vegetables as a really nice way to get that in. It has very little taste. That medium chain triglyceride, if you guys remember, it's metabolized through the liver differently as well. So it's quick energy. It does help, like I said, with constipation. It helps for people that need that satiation more often throughout the day. That's a really good way too. And it doesn't seem to cause as much gastroparesis as some of the other fats do. So it can be helpful for somebody that's experiencing that as well. When we go to phase 2, you can see some of the differences here is that whole grain or fruit is allowed more throughout the day. So it's still only one serving. If they're on this medication, if they have some insulin resistance, still limiting is important. But we also, we look at it from that gut health perspective and how important it is to get all those different fibers, and carbohydrates are definitely important as well. We try to stress to have leafy greens most days of the week as well. Some other things we talk about when you think about blood sugar balance and the order of eating would be starting with your vegetable, then moving to your protein and fat, and then finishing off with your carbohydrate. It will create a nice even balance and not spike the blood sugar so high. Okay, so what are people actually doing? And I do want to share what our results look like as well. Whoops. So people typically follow 80% of the diet, and about 80% of people follow that. So this is what I've heard from a lot of you as well, that they're not the best at sticking to it exactly. And we at Weighless MD, we have very structured programs. Those are the people that like to track. They want to know their macros exactly. And then it seems like the people on semaglutide, tirzepatide, they want that more relaxed way of eating. So what some people do is their weekends are more relaxed, and other people include 1 or 2 more carbs throughout the day. So essentially they move to phase 2 instead of sticking with phase 1. Then we have about 10% of our people. These are the ones that are on social media everywhere because they've lost all their muscle mass. They're not eating anything. So they think eating less will give them more results. And that's why those InBodies are so important, to go and get your actual body composition measurements done. Because yes, they might be losing weight very quickly, but what are they losing? We don't want them losing their muscle mass. And a lot of times that's what's happening, because they literally are forgetting to eat or purposely skipping a meal because they have no hunger. And when they actually see those results on the scale, they're like, wow, okay, now I understand the importance. I'll get my protein in more frequently, and we do work with them. And we meet bi-weekly to begin with, and I think that's really important to catch things and habits early. Or they continue to eat the standard American diet that they have been doing before, and they might see some weight loss, but maybe not. And their GI symptoms are horrible. So they're the ones that, they have the nausea really bad, the food sitting in their stomach, and they just can't tolerate the foods like they could before. So when we have these 80% of people who follow 80% or better on the diet, we see long-term results, 3 months and 6 months, of 1.5 pounds per week. We see visceral fat being decreased, and there's complete preservation of muscle mass. We even have some people that do actually increase their muscle mass as well because of some of the changes we recommend to them. Obviously some people are higher and some people are a little bit lower, but this is our average weight loss. It's really nice. So we try to have something for everybody. So you saw how we broke down the macros, or like balance a meal. We also have an app. So every day they get 3 meal recipes that are simple, or they can choose to, we use that Clean Life, and we've created recipe booklets. So they can choose to leaf through these booklets and see what sort of recipes they would like if they want to plan ahead. But some people like just, oh, that's a good idea. I'll make that tomorrow, or I'll add that to my list. So having that pop in their email every day is super helpful as well. So we like to make tweaks then. So you saw the baseline. We like to make tweaks based on labs. Here are some of our ideal labs. We don't ask everybody ahead of time to do these. People are spending a lot of money already on these programs, and to ask them to do additional things, it's not necessary. It's really nice from our standpoint and helping them long-term and to be able to tweak things. So in an ideal world, I would love to have all this information, but we don't always. Fasting insulin would be really nice to have. We want to know if they're insulin resistant. If they're not, we can move them right to phase 2. We don't have to put them on such a strict diet. When you look at the functional world, we have a much tighter area that we want these labs in. So at least under 10, but ideally somewhere between 2 and 5 for screening for insulin resistance. A1C is a great marker, but it's not always doing the best job because it's the average over the 3 months. So it could look somewhat normal, but someone could still have issues. They could be spiking high and then dropping and having hypoglycemic incidences as well. So if we're really looking at blood sugar regulation, a CGM, a continuous glucose monitor, is ideal. We've had some patients on it, and it's been really cool to see on these medications how quickly they come back down after a meal. Vitamin D is so important in weight loss, immune system, hormones, absolutely everything. And so many people are deficient. I'm sure I'm speaking to the choir, but I can't tell you how many people we ask that, oh yeah, my vitamin D is fine. Oh, can I see the lab? Okay, it was around 30. That is right at that borderline. And in our mind, that's not ideal. I usually shoot for 60, but anywhere from 45 to 80 is in a good range. Nutrient deficiencies have so much to do with being able to lose weight, the B vitamins, iron, so anemia sort of things, the minerals like magnesium, zinc, and selenium. Now, if people do not lose quickly or on pace of what we normally see, then I really am looking to thyroid and hormones to be more of an issue. So make sure when they're doing the thyroid labs that they're getting the T3, the T4, and antibodies so that we know, is it autoimmune related? So that T3 it's converted from T4, and there are certain nutrition components that are really important in order to make that active T3. Hormones can also be tricky because they'll get them drawn and it's a one-time blood draw. And hormones fluctuate all throughout the day. And it can be really hard to catch a hormonal issue by just doing a blood draw. So I really prefer the Dutch hormone test. It's a 24-hour test of urine, so you can get a better snapshot of what is actually going on. And you usually do it for a menstruating woman on day 19. I have to put a plug in there for the stool testing. Since so many people have GI issues on these medications, it's essentially exacerbating an issue that's already there. The gut does so much related to weight management. We had talked about earlier, it affects short chain fatty acids are a byproduct of certain bacteria in the gut, which can really influence insulin sensitivity and appetite. The gut is breaking down these calories, this food into calories, and it decides how much is actually getting to our body. So we can have excess calories going to the body versus less calories, for example. Inflammation is a huge piece. When we have low-grade inflammation in the body will not lose weight effectively. So dysbiosis, the overgrowth of bad bacteria, not enough good bacteria, causes this inflammation. LPS, lipopolysaccharides, can be tested and are usually a huge piece of inflammatory issues that are in the gut. The gut regulates hormones that affect appetite and fat storage and the feeling of fullness. So important there. The gut brain connection is such a strong one. That's something that, when people are stressed, where it's, it starts in the gut, or if they're stressed, does it cause further gut issues? It's like a back and forth highway. And something that's why stress is so important when we talk about gut, when we talk about weight loss. And cravings are a big issue for people that have candida overgrowth. So if we screen and find that, it can be a real problem. These are the people that you hear say, I can't go a day without my chocolate, or I always have to have sweets. I've always had sweets. And what happens is you just end up overeating because you're constantly wanting that sugar and carb. So some of the tweaks we make based on symptoms or conditions. So if they are coming in already with gut issues, we might start them on more easily digestible foods, more cooked versus raw vegetables. We might add some like sun fiber to bulk up the stool a little bit as we're increasing vegetables in the diet. We might promote motility, bitters potentially, or like vagus nerve sort of exercises like humming or deep breathing before eating. Those things can be really helpful to keep that motility robust. Then we also look at the thyroid dysfunction. So if we see that there's issues, maybe it is just T3, we'll want to make sure we include plenty of iron or iodine rich foods, selenium rich, zinc, make sure their iron status is fine, their vitamin D is fine, they're getting good vitamin A and omegas as well. All those are really important for the nutrition for thyroid. And then this is a big one, the low muscle mass or losing muscle mass. So if someone comes in already low in muscle mass, this is a discussion we have before they even get started. But we're also thinking, are they actually digesting their proteins? Is it a hormone sort of thing? As women age and estrogens go down, that can really deplete or make it more difficult to maintain muscle mass. So we start with, okay, are you eating enough? Then are you digesting it well? And some of the things we look at, I'll look at total protein in a lab as one way, but then I'll also look at their GI symptoms and, are they not producing enough hydrochloric acid, for example, because that will affect breakdown of proteins. They need to get resistance training. That is like key number one. So getting them at least 2 to 3 times a week, doing something simple to get that muscle mass going. And then we would look to hormones if if everything else looks okay. Here are some of the great resources we have to address these issues. We have a gut forward eating plan. So it's all about reducing inflammation in the gut, supporting digestion, and balancing gut bacteria. We have a total gut reset program. So sometimes we'll stop people for 30 days or have them do it at the same time at a lower dose to help build the gut bacteria and help with digestion. And then we have a really nice maintaining and building muscle while losing weight, because that can be tricky. While you're cutting calories, you still are trying to preserve or even increase muscle. It takes being very specific about enough protein and enough calories and the timing of protein, making sure you're getting quality proteins, all of that. So we will be sharing these handouts with you as well. This is a nice patient handout, but I mean, just sit back and look at this for a minute. These are all the things we say, and the what to eat, these are known to increase the GLPs. And on the other side, on the right side, it's the things that cause GLP to diminish. So it's everything we've known before this. So nothing essentially has changed. It's just, I think people, when you can say, oh, this boosts GLP-1 or this stops the GLP-1 from working, it's created this new motivation and this new thing for people to, reason for people to follow this. So we have a handout on this as well. So I want you to take a minute to think about what today you want to start implementing with your patient. So maybe it's using some of these handouts. Maybe it's looking at the gut more closely or their labs more closely ahead of time. Also think about the possible things to address with them, the challenges. People come into starting GLPs with all of this past information. So what they've heard on social media, what their friends are doing, what family has said based on all of this. So they have so much built up before they start. So sometimes it's breaking down those things and setting realistic expectations. And then what could you potentially use nutrition-wise to avoid some of those symptoms or side effects? So in summary, patients on GLPs are treated very similar to other weight loss patients, right? Because when a patient is overweight, they have metabolic dysfunction. They typically have insulin resistance. It's very rare that that's not one of the components of it all. So it's treated very similarly. But I think that customization piece, listening to the patient, all the behavior changes that are made along the way is very key. And they will not be better off if they don't fix those root issues and behaviors. So this is what I see, like while they're on that medication, that is the time to slowly implement new behaviors and new changes and heal the gut and, get that energy back while they have that support of the medicine so that they don't have to be on it forever and they can feel safe and comfortable coming off of it. Because coming off of it is one of the hardest, the scariest things for people. One of our whole sessions, Sherry's last session, is completely on long-term maintenance. So how to come off of it and what to do for that. Here are some of the resources that will be in your Thinkific portal, resolving constipation, reducing reflux, which are the most common things we see, maintaining and building muscle mass, one of our recipe booklets, those 2 one-page meal plans, and then the patient-facing what to eat, what not to eat handout. Thank you so much for your time today. We'd love to get your feedback throughout this program. Each module has a feedback section, so please share and ask any questions you have that were not covered.